Good morning.
Thank you. Do you think I should go ahead and share while you submit?
Yeah, sure. That would be great. It looks good.
Mute, but thank you so much. Yeah.
Good morning. Good morning. Good morning, everyone. Welcome to OBGYN Grand Rounds. In just a moment, I'm going to ask Dr. Rosenfeld to introduce our Grand Round speaker. But first, just a word or two about attendance. We will be taking attendance for department purposes after 8:10 this morning. If your name is displayed clearly, then you will get full credit for your attendance. If there's two people on one computer, or if there's a computer phone number displayed, then you can email your attendance to Millie or Michelle or Beth or I. And with that, Dr. Rosenfeld, are you ready to introduce our speaker?
I am. Good morning, everyone. I am honored to introduce Sarosh Rana to present our Grand Rounds today. Dr. Rana is a professor of obstetrics and gynecology at the University of Chicago and the section chief of maternal fetal medicine, as well as the Health System Chief Obstetrical Transformation Officer. Dr. Rana completed her medical training in India and her OBGYN residency at the University of Chicago, followed by a MFM fellowship at Brown and an MPH at Harvard. Over the past few decades, Dr. Rana has focused on the pathogenesis of preeclampsia. She was one of the key contributors to the recently approved SLIT PLGF assay in predicting preeclampsia. In her mission to improve outcomes for women with hypertensive disorders of pregnancy, she has worked on identifying racial differences in maternal comorbidities, peripartum characteristics, and outcomes in those impacted by preeclampsia. To reduce morbidity related to preeclampsia at the University of Chicago, she has been leading the systematic treatment and management of postpartum hypertension program. She's also a dedicated mentor for researchers at all levels and has always been incredibly generous with her time. On a personal note, Dr. Rana was invaluable in helping me with my thesis study during fellowship. I'm very excited to hear more about her STAMP program at U Chicago and hope you all will join me in offering a warm welcome to Dr. Rana.
Well, thank you so much, Emily. And yeah, I hope it all worked out well. We have to maybe connect later, but thank you so much for inviting me. And today, thanks. I can't really see you guys, so I know that if you guys have questions, you can put it in the chat, but the presentation is not very long. So hopefully we'll have some time to talk later on as well. So I will not be talking about biomarkers. Essentially today, we will be talking mostly about what Emily was saying, is eliminating racial disparities. And I know you guys have a fantastic program too, so perhaps we can, have some opportunity to talk about that too. So I don't have much time today to talk about this role that I have, which is the Chief Obstetrical Transformation Officer, but maybe if anybody's interested in figuring out what that all means about, I'm happy to talk about that too. I do have some conflicts. I work with some of these companies like we were talking about to develop the biomarkers, which are now FDA approved, so it's a good thing. So today though, we'll be talking about, and some of this information is hopefully not very new to at least to most of our OBGYNs and as well as the learners, but we will understand the gap in the postpartum, just in general postpartum, but also in the management of postpartum hypertension, and talk about the specific program that we developed here at the University of Chicago several years ago and how it's helping us manage blood pressures and eliminating disparity in this particular area. So we are calling it STAMP hypertension, which essentially is a simple catchy phrase, and it stands for Systematic Treatment and Management of Postpartum Hypertension. So we all know this, but the pregnancy-related maternal mortality, which is called PMR, and it's this is a little bit of an older data now. I think it's from like 2021, but this is the PMR in Illinois. So you see that on the left side, the black bar is all across US. It's close to like 17, 18, and you can see here in Illinois it's much higher. But Black in Illinois are at significantly higher risk to have maternal mortality as it pertains to deaths during pregnancy or postpartum. And essentially, again, this is CDC and data, and this was kind of catchy at that time to me when I started looking at the postpartum period. And obviously, ACOG has so much guidance around that too. But if you look at this, about 1/3 of the deaths in moms are happening during pregnancy, but a large majority, 2/3 of them, are occurring postpartum, and among those 2/3, about half of them are occurring at the time of delivery and within 1 week postpartum. So you can imagine if there is some change that you want to do in terms of significant morbidity and mortality, perhaps intervening immediately at the time of delivery or immediate postpartum, even for the 1 to 2 weeks after postpartum, may have a significant impact and reduction of that excess morbidity. So when we talk about, and this is again, I wrote an editorial a couple of years ago with one of my fellows, we started looking at so what would be the different factors that contributes to disparity? And we were my lab works out of just hypertensive disorders and preeclampsia. So we wrote this more in terms of how does racial, how does kind of there are disparities and why they are just pertaining to hypertensive disorders, but I think you can apply it to anything: diabetes in pregnancy, obesity in pregnancy, just overall risk of adverse pregnancy outcomes. So we think it's like, just like this is a little bit of a fish diagram that I made here. And we put this figure in the article, and essentially there are obviously several factors. And if you look at it, there are things such as access to lack of quality care. So that's, I don't know how many people read that, but there is a JAMA article, which I think just came out like yesterday, which were talking about access to MFM care. And it's very, very actually concentrated on the East Coast, West Coast, and in Midwest, it's very poor. So about less than, at least that article said that less than or just over 50% of the people who even need MFM care get MFM care, and there's like almost like very, very little telehealth and things like that. So obviously there is lack of access to care, but among Black people, there's lack of access to even, so not just access to any kind of care, but access to quality care, which I would say, for example, access to MFM or access to high-level ultrasound. Then obviously people are entering their pregnancy with higher risk. So there is high risk for obesity, uncontrolled chronic hypertension. We've all seen those patients with obviously diabetes. Where we are in the South Chicago, there is lots of things such as housing insecurity, there's gun violence, so that contributes. And then I feel like on the bottom, I wrote some of the things that we as providers can perhaps, not so much like, I don't want to use the word contributing, but are part of at least the healthcare system. And there are all these biases that we have, provider implicit biases. One of the factors that we looked at, and not recently, but a little while ago, was lack of awareness. And there's lots of data from other places as well. So there's lack of awareness and education, not just among the healthcare providers, but also among the patients. And then there's a common scenario that patients, especially Black patients, they say they are unheard. Their follow-up care plans are either not there, or even if their follow-up care plans are there, they're ineffective. So it's like a whole lot of things that are happening around this person that leads to this disparity and obviously adverse outcome. So when we started looking at this, and this was in 2018, I want to say summer of 2018. So I got to University of Chicago in 2014, and one of the first things we did was we participated in ILPQC, which is Illinois Perinatal Quality Collaborative, and looked at the management of acute severe hypertension and see how are we managing hypertension. So that took like a couple of years for us to be part of ILPQC. We created some data systems so that we can enter the data and started looking at antepartum hypertension essentially during kind of late pregnancy, whenever the person is admitted, or during, immediately at the time of delivery, intrapartum, things like that. But then I was like, okay, let's just look what's going on in the postpartum space. And this was in 2018 when ACOG did come out and say that postpartum period is very important. We should call it as fourth trimester, things like that. So when I looked at our hospital here, what we found that if somebody has hypertensive disorder pregnancy and they're being admitted, for example, for delivery or mostly for delivery, what we found at the time of that admission, when a person comes in and gets admitted, and at the time of her discharge, there was just really a general lack of knowledge among the patients about any kind of long-term effects of preeclampsia. So they were unaware, and most patients, and we did several surveys, believe that and either the doctor told them that, or their mother told them that, or somebody in the family told them that, but they kind of were under the impression that once you get delivered, preeclampsia is going to be cured and it's not a problem, once you have your baby. In our hospital, at least, there was no organized effort to educate our patients. So depending on who's on service, and I know you guys are teaching hospitals, so it depends on who your attending is, who's rounding that particular day, or who the patient goes to postpartum on which service, there was like really no organized effort to educate them, but really very specific and dependent on who the person is on service. Then we were not really giving discharge instructions universally. So while ACOG was saying, all these patients with severe pre-E, maybe they need to come back in 72 hours if you discharge them home on medications. And then patients need to be seen in like 7 to 10 days postpartum, universally if you have an HDP. At least at our hospital, we were not giving this universal discharge instructions. And even if we were giving them discharge instructions and telling them to come back, we really had no dedicated postpartum clinics where these patients could actually have easy access to care. So we were telling them, yes, come back, but obviously there was like no dedicated effort to even create some space for these patients. Then a lot of problems that we found was if these patients were, obviously there was like no organized way to send them out, and a lot of people were then coming back in through the ED. And when I went back and I looked at the ED, we actually found that in the ED physicians, and we have a level 1 trauma, so it's a pretty busy ED, they really had no way to identify a postpartum patient. So the postpartum patient will kind of sit in the same line as anybody else with cough, fever for 8 hours, 9 hours. Our average time between the patient coming and like kind of being triaged at her, when she comes in, compared to when was actually the patient being evaluated, sometimes would be in hours and hours. In the ED, they actually had very poor knowledge about postpartum hypertension. So I just could, not that I published this or anything, but I just did a quick kind of, go around, and I went and talked to several providers there, and they really didn't understand that there is an entity like postpartum hypertension, and, people can get really sick very quickly in the postpartum period. The other thing they were doing in the ED was they were either calling medicine or cardiology instead of OB. So once the person is postpartum and she comes in with shortness of breath, or she comes in with headache, or she has hypertension, they will just like admit her to a medicine service or admit her to cardiology based on, and a lot of times they won't even call the OB providers to tell them that the person is, in the hospital. This all led to really delayed transfer of care to L&D, for example, if the patient needed to come there. And then also I felt like there was a really delayed recognition, and there was really no treatment for severe hypertension in the ED. So their PICSs were not even equipped with IV labetalol or magnesium, or so, that just did not exist in their PICSs. They did not have IV antihypertensive and didn't really have any protocols for management of acute severe hypertension, which all of us should know is like repeat in 15 minutes and treat within an hour. So none of that was going on in the ED. And then the patient was actually fortunate enough to somehow navigate all this and be admitted. There was really no standardized management for readmission. So people were just treating magging, not magging. What's your goal for antihypertensive? How long should the patient be admitted to the hospital? Who should be the primary service? None of that. It was very, very not standardized. So what we did was we kind of sat down and we said, okay, the whole system needs to be like worked around this, particular problem, obviously. So we created a bundle. So bundle approaches for residents here as like things that you do for around a thing. And there are various different interventions for different things. It could be just like, medication combined with education, combined with X, Y, and Z. So bundle approaches are good because they can be specific to a particular condition, but bundle approaches are also hard to evaluate because you don't really know what particular component of the bundle was actually the most successful. So then the only way you can interpret the data is saying you're going to take all the things that I did, and you got to apply it to a different system, and that's how it's going to work. And, a little bit different than when we think of like a drug treatment, you can say, yeah, this drug causes X, causes Y. So I think bundle approaches are hard, but bundle approaches are amazing for hypertension and management, for example. So AIM bundles are created around the same concept. So created a team, and I put that there because early on when we were putting this together, it just really felt like it was like a snowball. We were trying to push it up. So I have a very large team, and early on I had lots of medical students and fellows giving their time in creating these protocols and creating my posters and doing a lot of education around that we did. And now we do have some funding from different sources. I'll talk about that. So one of the things that we were kind of from the very get-go, we were saying that this is a very kind of a quality improvement project. So not to like step on anybody's toes, we were like, okay, we're gonna like really take this on and improve the quality for all patients who come to the hospital and get admitted with high blood pressure and pregnancy, and how we manage the postpartum blood pressure is part of this program for every patient. So we had some big goals and some small goals. So one of our goals was really to educate all the providers and patients. So any provider, so whether it's your, obviously your nurses, your doctors, your midwives, your residents, your fellows, anybody who would be attending to this patient's care as a provider needed to have a formalized education. And we created competencies that everybody has to take, annual competencies for hypertension, and we just added the postpartum hypertension as part of that. We did a lot of education around ED as well, and I'll tell you how we kind of worked on that system. Then we also did a lot of patient education, obviously, as part of the education system. So we created a video, I think I have it on the next slide, that every patient has to watch before they can actually start watching their TV. And it's part of their kind of, anybody who gets a diagnosis of HDP, that gets assigned to her and she has to watch that. Then one of our, actually the real goals was really appropriate and timely management of postpartum hypertension. So again, we kind of, stuck with the AIM bundle, which was essentially the treatment of acute severe hypertension. And then, the postpartum hypertension, if you actually look at it, the data is quite variable in terms of what should be the goals for initiation of antihypertensives, how long should you keep the patient in the hospital prior to discharge. Like a lot of that was unclear, and I think it's still unclear. There are no good large randomized trials against each of these situations. So a lot of these things that we created, I just read the literature and I got some consensus from rest of my MFM group, and we said this is how we're going to manage hypertension in the postpartum period. Then the other kind of our big goal was really we wanted to improve the rates of postpartum hypertension follow-up. So I'll show you some data, and nationally, so when I was looking at this, nationally, the rates of postpartum hypertension follow-ups are very poor. So in some places, it's been reported as low as 30%. And then it's actually much disparity in terms of how people are coming back, whether they are African American, Black versus white people. So there's lots of disparity and very poor rates of follow-ups in general across the nation. And then obviously our end goal was to reduce some of these hypertension-related complications. And then the other thing that I really wanted to kind of look at and improve was really this kind of readmission. So even if you can send them home correctly, this whole readmission pathway had to be obviously looked at, and we wanted to update that as well as manage the readmissions correctly. And then something that we are still working on would be obviously your long-term control of blood pressures up until like 1 year, for example, so that the patients can actually improve their long-term cardiovascular outcomes. So what did we do? So we did a lot of things that I call like clinician buy-ins, and then several procedures that we put in place. So I can tell you that even before we started thinking, we had to like sit down with a lot of, very, very important stakeholders, such as our labor and delivery director, our quality chief, pretty much all my MFM section, as well as the providers who are delivering care in the delivery suite, as well as our mother baby, like the postpartum floors. So this is the video. It's actually right now it's on YouTube. Anybody can download. There's nothing proprietary about it. It's been there for several years now. So this is on the Care Connect. That's our care network, which is kind of our Epic-based the video that we show our patients. We did a lot of work with our FBC's Family Birth Center and a Family Birth Center nursing. So I had to involve the nursing leadership. And in fact, the whole plan of like this whole STEM hypertension program was actually started with me and my nurse, who was my research nurse, as co-directing this. She's actually an amazing person. So she did a lot of education for the nurses and created all the kind of educational materials for them. For the patient education, we are giving them, so now we are a little sophisticated. We have a little bag that we give to each patient. So in that bag, this is this thing from Preeclampsia Foundation. It's a tear pad, very simple. You can just tear it off. It says you're still at risk after your baby is born. So this whole concept, and I wrote several review articles, but also book chapters where you have to literally erase some of those sentences which it says preeclampsia is treated by delivery. So you have to erase that from your memory. Preeclampsia is not treated by delivery. It's just like the symptoms resolve, your condition may improve, but your lifelong risk to have literally even dementia, renal dysfunctions, cardiovascular dysfunction, lots and lots of data. So, and then obviously in the immediate postpartum period, people are at risk to have even stroke. That's one of the common things, heart failure. So this is a pamphlet which says you're still at risk after your baby is born. So kind of just like emphasis on the word after, so that the patients understand. We give all our patients written instructions. We bought these bracelets, again, very, very cheap. They are actually, you can customize them. So we customize these. They're purple. Purple is the color for preeclampsia. Just by convention, several organizations are using it. So we buy these purple bracelets, and it has postpartum on one side and preeclampsia on the other side, just so that it's, again, very specific. And we tell our patients, if you end up in any ED, anywhere, you can just show this bracelet to them and say, hey, you know what, I am at risk to have postpartum complications because I had preeclampsia in my pregnancy. Then we are giving them blood pressure cuffs and monitors, and I'll tell you more about it. These are free of cost to the patient. And now we're doing remote patient monitoring. But when I started it, I literally just went and bought like some blood pressure cuffs out of my own money. Not my own money, but like my research money, like about 300, 400 blood pressure cuffs, and started giving it to patients for free. Then we have this preeclampsia discharge checklist. We're still using this paper checklist. So everything, all of this is now electronic. And there's a team of people who are providing this education, and they have to check box on the Epic. Like there's like 4 boxes that they have to check whether the patient watched the video, whether you give them the blood pressure cuff, whether she's enrolled in the RPM program, and whether she has this, postpartum appointment. So anyway, but we are still using this postpartum preeclampsia care kind of this discharge checklist, which is very simple. I think I have it on the next page, but essentially we write down what antihypertensives you are on, and then we have just like really simple traffic light kind of a situation. Normal blood pressure is less than 140 over 90, hypertension crisis more than 160 over 110, and anything in between is hypertension, so patient can understand what her blood pressures should be and what to do with each of these blood pressures. Like I said, we do this annual competency for every provider, so it's for any provider who's practicing and in our labor and delivery. I'll show you some of this, but we standardize pretty much all protocols for management of postpartum hypertension. And this may seem trivial to you, but it's not trivial. To kind of want everybody to manage blood pressures the same way, and it's a large dream. I work in a large hospital. It was one of the hardest things to do, but I think we are doing a good job with this. But I had to like write this down and kind of get a consensus around that this is how we are going to treat the blood pressure, starting from the time of delivery while the patients are in the hospital, up until 6 weeks while they're being seen in the clinics, and obviously at the time of their visits when they come back in the postpartum period. Then we had to standardize all the protocols for readmissions, which we did. And also I'll show you, we worked on the ED workflow, which was also a little bit not that difficult, but was kind of at that time seemed novel. And then what we did was we actually created postpartum hypertension clinics. These clinics are essentially now being run by my physician assistant. So any patient, whether they are private patient, public, Medicaid patients, transfer patients, anybody's patient who delivers here, they kind of go through this postpartum hypertension clinic and gets managed their postpartum hypertension standard fashion by my PAs. There's like a whole team of people who do these clinics kind of a couple of times a week, so that they have lots of access into, and it's all telehealth right now. But we started out not by telehealth, and I'll show you how telehealth really helped us. So these are some of the, and again, this is not something proprietary. Obviously, we had to make this by I think it's up to the 8th standard. So there's a literacy, I'm pretty sure you guys have it. So we had to run it by them, but it's very simple. It just tells you what are your symptoms, know your risk. When the appointment is made, so one of the big things we do is like we make everybody's postpartum follow-up appointment, which is like 7 to 10 days up to 2 weeks during that window. Based on what they have. If they have severe hypertension, they get an earlier appointment. If they have chronic hypertension, maybe within 2 weeks. So this appointment is made and the appointment time is already written in here. Then what are your antihypertensives? And then this is an older sheet where patients were actually writing their blood pressures. We do remote patient monitoring now, so no more writing, but we're still giving them the sheet just for education, so they have them. Then we have these very simple patient education materials. The aspirin one, I just put the plug for aspirin here. The way we have it in the pregnancy is that in all our clinics, we have our MAs. When they're checking in the patient, we actually give this to our MA so that they can, give it to the patient to remind us. But we should all be giving aspirin, obviously, to all our patients who are at risk. This is the antepartum. I don't know if you guys have ever seen this, but this is from the Preeclampsia Foundation. It's very simple. This is for their antepartum patients. So I typically just give this aspirin and this preeclampsia sheet to the patients. And then we also have this Preeclampsia Foundation, again, has this preeclampsia and heart disease. So very simple English. You can, it's pretty verified. I think ACOG kind of recently worked, the Preeclampsia Foundation worked with ACOG, and they came up with some more education materials, but it's all free of cost to you. You can just order them. The only cost that they charge is really the shipping. So you can use a lot of these material, which is like very thoughtfully crafted and patient facing, that you can use it in your clinics and for your patient education. So I think one of the things that really helped us was creation of these dedicated postpartum hypertension clinics. So like I said, those are some of this is my patient actually, and this is my PA here and my nurse. So these appointments are actually made before the patient goes home. In this clinic, there's standardized protocol for management of hypertension, and typically this is occurring like 10 days, 2 weeks out from their delivery. The patients who have simple, so obviously we manage non-severe hypertension in the clinic, but anytime the patient has severe hypertension, right now our protocol is to send them to labor and delivery for management of severe hypertension. And then obviously at the 6-week appointment, when these patients are being seen, we do try to schedule them for a cardiology within 2 to 3 months postpartum. So essentially, this is a patient journey that I've been talking about. And the patient, so here at the time of delivery, we standardize the management of postpartum hypertension between delivery and our discharge. They have to watch the video. At the time of discharge is where most of these things are happening. So we do have a dedicated nurse educator who goes around, and now we have several nurse champions that we have identified on labor and delivery, several of them, as well as mother baby floor. But initially it did start with one of my nurses, and then she kind of educated the nurses to educate for the nurses. We have these inpatient hypertension protocols. We're giving written instructions and really educating them around warning signs, so headache, severe, shortness of breath, chest pain, all of those things. We're providing them with the blood pressure monitor. We give them the wrist alert bracelet, and we schedule this appointment. At this appointment, when they come back 7 to 10 days postpartum, like I said, these are dedicated postpartum hypertension clinics. They're providing them hypertension education. They're also telling them about long-term cardiovascular risk, and then following a protocol that we created for management of hypertension at this point in postpartum period. If they have severe hypertension, anytime during the postpartum period, they go directly to labor and delivery. If they are readmitted, we created readmission protocols. And then if otherwise nothing happens, she continues. And then at 6 weeks postpartum, again, this is the time that we kind of discharge the patients from our program, and then recommend that they follow with the cardiology or with the PCP. So what did all these things do? Well, we set out to reduce blood pressures and improve follow-up, and we were kind of able to achieve both of these. So essentially what we found was, this is a little bit of an old data now. It's all published. This was published in the Green Journal, but essentially what we found was the rates of every type of hypertension that you can think of was lower after the program was instituted versus before the program. So this is blood pressures 140, 190 within 24 hours postpartum, reduced from 80% to 46%. Blood pressure at this first postpartum hypertension visit reduced from 39% to 18%. Severe hypertension prior to discharge reduced from 32% to 7%. And then even simply blood pressures at the 6-week visit reduced from 25% to 14%. So essentially with the program, we didn't really discover a new drug, nothing. In fact, I'll show you the protocols. I left the antihypertensive. I don't really care what you give, but just treat her blood pressure, like keep the blood pressures low. So essentially that led to reduction in blood pressure throughout the postpartum period. But more importantly, what we found was there was significant increase in the rates of postpartum hypertension follow-up. So just bear with me, there's a little bit of a crowded slide, but these are the proportion of patients who are coming back for their postpartum hypertension visit. So when we started out, this was September to December 2018. The program kind of rolled out in 2019. It took me almost 6 months to put all the pieces in place. So this from January to June, we kind of, implementation phase, but really the program was totally up and active in November of 2019. So almost a whole year later. So what we found was then, and there are different components is in the paper, but we were obviously not able to do everything all together. So education came first, and then the blood pressure came next. So the average rates of postpartum follow-up in the entire patient population was 33%, and then we went up to 59%. So almost doubling of our rates of postpartum hypertension follow-up, and it was obviously very good data. But then when I broke that down by African American Black patients, which we have a large portion of patients here, about 60 to 70% of our patients are African American Black. So when I broke that down into Black and white patients, what I found was among the Black people in the beginning, the rates of follow-up was 30%, and in the white, the follow-up rate for 53%. So pretty significant disparity of about 23%. And then with all of the efforts that I did for the entire year, the rate of follow-up among the Black people went up from 30 to 54, so pretty good. And among the white people went up from 53 to 57. So essentially, again, for learners, and here what you see is obviously everything very, very significant. P was like less than 0.0001. But if you see here, there is still this gap. And the gap was is exactly the same. It's about a 22% difference between the Black and white people here at the baseline and Black and white people there at the end of the intervention. So what you call this, you call it equality. So we had a program which was pretty equitable in a sense that everybody got the same kind of care, right? Everybody went through the program and everybody got the benefit. You've heard that rising tide raises all. So similar to this figure on the left, and this I just stole this from SMFM. Well, what we need to do though, it was very clear to me, was that what I needed to do, I needed to create an equitable program. So people who are down here, who don't have as many resources or actually do not get the entire benefit as we want to have them, we need to create something bigger for them and better for them. So that got me into thinking about what are the different things that you can do to improve equity in any program that you are trying to create. So this is what happened. I didn't really think of it myself, and it just kind of happened automatically because COVID came. And essentially, because the program was running really well and all of us in the team felt really comfortable managing patients' blood pressures postpartum, we felt like, okay, maybe that could be a visit that could be converted. So I'm the section chief here. One of the things that we were doing at the time of COVID was really trying to figure out, and a lot of people obviously from New York and stuff were publishing papers about how you can convert pregnancy and not so much postpartum, but definitely pregnancy care into telehealth. So there were tons of data coming out, just like you can just convert half of these visits or 2/3 of these visits and do just telehealth with your patients. So one of the things that we and University of Chicago took on telehealth pretty quickly. They had all these pathways. You can write a note in the Epic, you can bill for it, and then you can just make an appointment for the patient, simple things like that. So they created a lot of processes to be able to do the telehealth. And one of the things that we early on said that, fine, we will just convert all our postpartum hypertension appointments into telehealth because we didn't really felt that the patient needs to come in. We can just kind of talk to them on the phone, and they all had blood pressure cuffs. So this is data that was published again in a couple of years ago now in 2022. So if you look here, the black line here represents the rate of follow-up among Black patients. The red line here represents the rates of follow-up among white patients. So if you see here, that's the baseline. So that's where I started in 2018. Then you see this gap, disparity gap here, about the one we talked about like 23%. Then with all the interventions that I did in my STAM program early on, when I was calling these patients back for their postpartum hypertension visit, there's still this disparity gap. And this is when we started doing the telehealth. So these blue bars are the proportion of appointments that were done by telehealth. And if you see here early on in February 2020, we were only like 15% of them. But by April of 2020, 100% of these appointments were made by telehealth. And when you see that, when you got there, there was actually no disparity. The rates of follow-ups among Black and white patients were the same. It was about 76%. So that was like amazing. But then obviously I don't have the data here, but the one thing that we always worried about, and sometimes when I was making these programs and now we're doing RPM, one of the concerns that people had early on was like, will not seeing these patients or will like increase the rates, for example, of like severe hypertension that is untreated, or perhaps your blood pressure won't be as good if you're not like seeing these patients in person. So we have in this paper, blood pressure, there were actually no difference in the blood pressure. The blood pressure control was similar. What happened was positive was that they had more follow-up for the patients. So more patients were actually checking their blood pressures and more patients were being connected to the healthcare providers. So then in about 2021, and this is when University of Chicago was actually looking into remote patient monitoring, and they had several programs. So they started a stroke program where they did home blood pressure, home monitoring. They had cardiac program where they're doing remote monitoring. So they came to me and they said, you know what, University of Chicago is going to float this program for remote patient monitoring. Would you want to do remote patient monitoring for your patients who are postpartum? And my program at that time was quite robust. We felt comfortable. I said, fine, I'll engage with them. So we, in my team, with the Department of Digital Health. So we have a UCM Department of Digital Health, which has all these managers and program managers. We had several meetings, and then essentially we worked with this company called Health Recovery Solutions. Nothing to do with me and the company. It's just a company that sells, blood pressure cuffs, and also has an app for monitoring blood pressure. So, you'll say, oh, why go through this? So I can tell you, it was a nightmare for me to find these blood pressure cuffs when I was doing this by myself. So I had to like literally, we went through the blood pressure companies, all kinds of things, and it's really, really difficult to buy the blood pressure cuffs in bulk. But this company solved all of it. If you go to their website, they're fantastic. But they were not into the postpartum space at all. They've never done postpartum monitoring. They were doing monitoring of like people at home and the older people. So I had to like sit down with them and spend almost 6 months of my time to create these postpartum blood pressure protocols and escalations and things like that. So this is our new sheet now. So this is everywhere in our labor and delivery. It's very simple. It tells the patients, what's going to happen once you're in this program. And then like some, we give this to our patients, but these are kind of posters and things that we have just for nobody forgets about postpartum blood pressure. So essentially it's a similar program as our STAMP program, except for now the patient gets a Bluetooth cuff. So it's a monitor with a Bluetooth capability, and they have to download an app on their phone, and they get enrolled in the program. The whole program is actually linked through Epic. So HRS has their own kind of portal where we can go in as providers and we can look at people's blood pressures, but it also connects to Epic. So this has been really good, though. Not so much that I'm managing everybody's blood pressures every day, but when my PAs are seeing these patients and doing telemonitoring at 7 days, 10 days, there is no gap in there. Patients will always come back and say, oh, I forgot my sheet. Let me find it. I didn't write it down. All that is gone now. The patient checks the blood pressure is already populated in the Epic. So I think if nothing else, it has really improved our access to look at their blood pressures. The rest of the components are still the same. They're still getting the education. They're getting the postpartum blood pressure appointments. ED protocols are the same. Every patient, like I said, discharged from University of Chicago is enrolled in this program who has any kind of hypertensive disorder pregnancy. And in the RPM, at least, we started enrolling in 2021. So this is our very simple workflow for a remote patient monitoring program. Essentially, the patient is taking vitals at home. They are automatically sent to Epic. The other good thing about this HRS is that they have telehealth nurses who are monitoring this 24/7. So we had to create, there are several kind of escalations currently in the system. So there are automatic escalations, which goes to the nurse, and then the nurse will call the patient figure out what's going on. And these escalations are essentially around severe hypertension. If there's any blood pressure more than 160 or 110, and the patient gets symptom surveys twice a day. So she gets a survey on her phone saying, do you have any headache, shortness of breath, chest pain? And if she clicks yes to any of those are automatic escalations too. Everything else like non-severe hypertension, medication adherence, those are non-real-time escalations, but they do get escalated to my team through emails. So, but at least in this case, when you have a severe escalation that goes, and then we have, obviously, you guys probably have the perinatal network as well, and then we have MFMs and fellows and all that covering this pager. So during the daytime, it's different people, but nighttime, but somebody from the UCM gets alerted if a patient has any escalation, and then the UCM provider will contact the patient and treat accordingly based on like whether on the phone, increase their antihypertensive, call them to emergency room, whatever, call them to labor and delivery, whatnot. So essentially, we just overlaid the system of automatic escalations and data in the Epic. And this is also very nice because these telehealth nurses, they actually write their notes in the Epic. So when you call the patient, you actually know. And if somebody's seeing them later on, there's like nothing, everything is very, very transparent. You can actually figure out what's going on with the patient. So this is our now kind of our workflow that we have in terms of, so this is, again, this is our bundle, and it's around this condition, which is postpartum diagnosis, postpartum patients who had a diagnosis of HDP, hypertensive disorder pregnancy during pregnancy. So we do provider education, patient education, wrist bracelet, warning signs, blood pressure monitor, Bluetooth enabled instructions, postpartum hypertension clinics, and I'll tell you about, we recently involved community health workers in our program too. So these are our protocols, and again, they are actually in the green journal, they are all open access. I think it is. I just published the RPM paper. So I again put all of these in the RPM, and I made that open access too. So there's available to all of you who wants to use this very, very simple protocol. I wanted to make it, a little bit not complicated so people can actually follow. So when you have severe hypertension, you just give them antihypertensive or magnesium. They have non-severe hypertension, just try to control the blood pressures. And essentially this is little minutiae, but you can decide for yourself. But we are kind of preeclampsia with severe features. We try to keep them for 2 to 3 days. But if they have a clinic appointment, they are compliant. They say they'll be compliant. We've been sending them home day 2 for vaginal delivery. But if you have chronic hypertension, you can go to day 2. And then some of these things are just like a little bit for the residents, mostly that if you have severe gestational hypertension, treat them as severe pre. So nothing fancy there. This is a little bit of a loaded protocol for readmissions, but essentially the thing to remember here, this is also published, is that all of these patients who have any kind of readmission for hypertension get admitted to MFM service. And that just changed the entire paradigm of these patients. So anybody, anywhere comes back to the hospital and has hypertension and she requires readmission, they will be admitted to my service. And essentially, again, here, if you have severe hypertension or if you have HELP, we are giving them magnesium if they never had magnesium before. The remagging is like really based on MFM, who's on kind of physician preference. Personally, I do a lot of research around preeclampsia, so I'm really worried about neurological complications. So I remag people if they come back with a neurological complaint. Otherwise, I'm kind of not remagging them. So here are, if you have severe hypertension, do what? If you have hypertension with any other end organ damage. So we do have patients who come back with heart failure. So we keep them on our service and we consult cardiology. If they only go to cardiology, service themselves primarily if they really have cardiomyopathy, but otherwise we just like monitor them on our service. If they have CNS involvement, obviously we call neurology. And if you have non-severe hypertension, you can just treat their blood pressures. This is a very, very simple ED protocol. So we kind of essentially, after long discussions with the ED and kind of doing lots of conversation with them, I found that it will be impossible for me to teach the entire ED staff how to treat hypertension. So essentially what I created was very simple protocol. I identified a pivot nurse who's a person who triages patients. So first of all, we're telling our patients, don't go to the ED. We tell them if you come back to the hospital with your hypertension, go directly to labor and delivery. All our protocols of escalations that are in the HRS system, in the RPM system, say explicitly, if we call the patient, anybody calls the patient and she needs to be coming back to the hospital, we tell the patient, come back to labor and delivery. But if you randomly show up in the ED, this pivot nurse will take her blood pressure and ask. So 2 things she has to do: take the patient's blood pressure and ask her, did she give birth in the past 6 weeks? And if the answer is no, if the answer to any of those is yes, send the patient to labor and delivery regardless of her blood pressures. So we are just telling them no need to figure out what's the diagnosis, call who. if you have hypertension and you're postpartum, just go directly to labor and delivery. Unless, obviously, if the patient is in frank heart failure, respiratory failure, or actively seizing, which is a small proportion of patients, then they call this OB resident stat pager, and then we go down to see the patient, but all of the patients otherwise directly come to labor and delivery. That worked out really well. This is my newly improved protocol, and if you see here, the goal blood pressure in the postpartum hypertension clinic. So once you're discharged from the hospital and you're like floating around between week 1 to week 6, our goal blood pressure here is less than 120/80. So and again, we can have a discussion and you can argue, but I was part of the AMA, and we're gonna come out with a paper in JAMA, and we put that in there that blood pressures in the postpartum period should be controlled as any normal person, and normal person blood pressure is like 120/80. So here are some kind of simple guidelines for my PAs when they're seeing the patients. So if you're severe hypertension, obviously you go to labor and delivery and follow the readmission protocol. If you're non-severe but higher than 140, you can increase your dose, add a different medications. If you're between 120 or 140, you just follow your blood pressures. And if you're less than 120/80, sometimes we taper them, but a lot of times I just like try to float them so that they can get their blood pressures out to like 3-4 weeks and then see if we need to reduce them. So this is kind of my summary slide here showing what did we actually do with all of these different iterations of my STAMP program. So this is our baseline. This was our STAMP. This was our STAMP telehealth. And what happened with RPM, there was further improvement in rates of postpartum hypertension follow-up, 88% in white people and 81% in African American people. And essentially what we came out and we said that this program led to overall improvement in rates of postpartum follow-up from 30% to 81% among Black women, and essentially eliminated disparity in the rates of follow-up. And these are our this is again just published in the RPM. And what we found was it was not only just improvement in the immediate postpartum blood pressures, but also improvement in the entire. So this is the 6-week data where we increased from 64% attendance in the 6-week visit to like 80%. In white people, it's like as high as 90% attendance through the different, and RPM attendance is even higher. So I feel like somehow if the patients are connected to this app, they have a high chance that they will actually attend their postpartum hypertension visit. We have surveys and all that we keep doing. I think I have a survey slide. So this is the data that is already published. And essentially what I'm tracking these patients. And the other good thing about the RPM is that you can actually meet with them frequently. So they have a portal. They can download the blood pressure data directly from the portal. So these are all patients, the rates of blood pressures, which is 40. This red thing is the hypertension, which is higher than 140/90. So that's what ACOG is currently telling us to treat. That blood pressure goes from 42% to 14%. So obviously, but I'm more interested in either normal or elevated or even, so this other category, which is 25 and 14 and 46. I think the biggest difference that we will feel if new guidelines will come out will be just this treating these blood pressures, which are just below 140. I think even now, a lot of my physicians are there just treating blood pressures higher than 140, which is fine. So this is interesting again, and I have to like figure this out a little bit. When I divide this blood pressure data into patients who are Black patients and white patients, so the graph C here is among Black people, they do not reduce their hypertension as good as the white people. So not that they're not getting antihypertensives or they're not coming back, but they go from 43% to 22%, while white people, the hypertension, at least as defined by ACOG, is gone by 6 weeks. It's only 2% of the people. So there's lots of difference in the as blood pressures measured at 6 weeks among the patients who are actually checking their blood pressures. And, in this paper, it was hard for us to say why. We couldn't really find out a reason, though in non-pregnant people, there is data that Black people have more hypertension in general in their life compared to white people. So I don't know what it is, but definitely we found a big difference in the rates of hypertension at 6 weeks between Black people and white people. So quickly about what are the patient's perceptions regarding RPM. Well, this is also published. Again, patients was like very, very positive. They said they will attend there. They feel like they are able to manage their blood pressures. They report that they are able to attend they will attend the postpartum hypertension visit. They also say they were going to recommend this to other people. And then they are also like more aware of their health, even beyond the RPM. So I did a survey of the patients all the way out to like 9 months and 1 year. And even then they retain a lot of knowledge, what was being told to them through this program. And the program has, now I've attached several videos to the program itself. So once you have this app, and it's not very fancy, but I attach some of these things from the Preeclampsia Foundation. I attach my own video in there, so patients can go into the, there's like a resource page that they can access if they have questions about their blood pressures, and some links that they can go to. So definitely, like, this is not that survey. This survey was only done up until 6 weeks, but I have like a 9-month survey. I haven't published it yet. That says that patients retain a lot of this knowledge that we are telling them around the time of the delivery and postpartum. One problem that we ran into, and it's not all this rosy, is this non-compliance. Non-compliance is defined if the patient is not checking their blood pressures. And I define non-compliance if you're not checking your blood pressures at least for 2 weeks in the 6-week period. And as we can see here, after week 3, the rates of non-compliance are just climbing. So in the week 1, only 14% of the people are not checking. By week 3, 39% of the people are not checking, which is kind of acceptable. But after that, by week 6, 60% of the people are not checking. So obviously the question is, do they really need to be checking their blood pressures all the way this rigorously for 6 weeks? Who knows? But at least for the first 1 to 2 weeks, they are checking their blood pressures, and they are definitely coming back for their postpartum hypertension visits. One word about community health workers. So to improve some of this compliance, but also to provide another support to the patients, we actually involve community health workers as part of this program. I haven't published the data either, but the community health workers actually have been amazing for our patients. So they're doing all of this. So they're obviously doing this cultural mediation. They provide them with some health education and information. They're offering them this, navigation through different referral services. So if the patient has to go to cardiology, the CHWs can help them. We have FQHCs, which are federally qualified health centers. So CHWs help them get there. They're providing coaching and social support. They're really good patient advocates. They provide some direct services, such as housing and all that. They are conducting a lot of outreach for us, and then they also did surveys for me. And I did a survey of the community health workers, but community health workers also surveyed my patients. So I think it's been like really amazing thing for us. And this is the community health service worker survey that I gave to the patients, asking them, do you really like the community health workers? And this is strongly agree, and neutral. So everything that's green is actually good. So community health worker, easy for me to reach. They know the important issues about my health. So overwhelmingly, the people, like patients, actually like involving community health worker in this postpartum space when they're managing their blood pressures. I think this is my last slide. So how did I fund all of this? That's a kind of a question that comes up all the time. I mean, I think if you're sincerely interested in doing the program, this actually is quite a bit of services that are reimbursable. But I was running it initially from my own department, and I got some funding from the Women's Board. And, these are like smaller funding opportunities that all of you can apply and get it from your own hospital. I got some funding from the Preeclampsia Foundation. And then I wrote for this HHS award, which were giving out money just to do that. And I can add 2023 as well. So we got it in 3 years in a row. So that was some money, but now it's currently funded entirely by the hospital. So the University of Chicago Health Equity Initiative is funding through the IT strategic program. So none of my patients pay anything for the entire program. It's just running through an equity kind of lens. It's free of cost to all my patients, and it is a standard of care for all our patients. And we enroll about 70 to 90 patients per month. And since I started this program, I was just looking, we've enrolled over like close to 6,000 patients in this program. And one last thing, so we got lots of awards and accolades. Very recently, we were given this Bernard J. Tyson National Award for Excellence in pursuit of healthcare equity. And I'm fortunate I'm talking to you guys, but I do have a slide to tell you, okay, what do you want to do in future? Well, I really want to expand this program beyond 6 weeks, but also do remote patient monitoring during pregnancy. So that's kind of the one thing that I was trying to figure out how to do that. And then conducting some of these behavioral interviews. I really want to understand what makes a person non-compliant. Like, I'm doing all of this, I'm giving you the blood pressure cuff, it's free of cost, I'm giving you all this education, you have equitable access, there is no access problem, and still you're not checking your blood pressures and not coming back. You can, simply picking up the phone. So I'm like really trying to understand from the patients, like, what is that is still prohibiting them to get their care. And then obviously one of the plans that we have is to extend it to other healthcare facilities nationwide. And then this is actually was included in the good clinical practice by the CDC and also by ACOG. And if you're coming to SMFM, I'm giving a talk with the CDC about just using this. This is a graph that they just showed me. The red are the ones where this program, my program. So I meet with people, and then I just educate them a little bit and tell them how to run the program. So all these red places are where the program is active and running. And then this green one is where the program is actually in development. So these are simple steps that I would leave you guys with this. We do have 10 more minutes. So steps for implementing this. And I do have a sheet now I developed where I will send that sheet to you, and you can click on different resources and it takes you step by step. So you get this initial email. There is a webinar that I did with the HRS, which explains how to use the program. We do program orientation with us. So we do a Zoom with my team and with the HRS team and with your team. Then we meet with the some stakeholders, such as, you can meet with the nurse educator here and say, how did she kind of approach this? Then we have, a few workflow meetings. I'm not big part of those workflow meetings. My team here is with the UChicago team and the HRS team. And then you do some work meetings with your, clinical research nurse if you're interested in collecting the data. And then you can also come to University of Chicago and see how we are actually doing this. So I do work in a large institution. Like I said, I have tons of people here. Actually, on this slide are mostly working on the biomarkers. For example, these two people, Erin and Marley, they are my kind of my research assistants. Colleen here, this person here with this stethoscope. I know you can't see my cursor. This person was actually the co-director of this program, and me and her started this while ago. I have research fellows and other fellows who are also helping with the program. And then, like I said, through the years, we've been funded by various different organizations. And then I do celebrate a lot. I like cake. So we bring cake every time we go there. This is our team up on labor and delivery. And this is the award that we got with JACO. And obviously we, I don't know what we were doing here. We're presenting it somewhere, I guess. And we put that picture on the cake. So that is all for me. And I will be very happy to answer questions. We do have some time.
Dr. Rana, thank you so much for that excellent talk. Are there any questions? I see Dr. Rosenfeld has her hand up.
Thank you so much for that excellent presentation, Dr. Rana. I have a number of questions, but my first one, and then I'll leave some time for other people, is you had mentioned that you were titrating or starting medication to a goal of 120/80. Are you just not decreasing medication unless someone's below 120/80, or are you increasing medication if someone's consistently over like in the 120s/80s?
Yeah, so we try to bring them down below 120/80. I can tell you that's a little bit of a hard thing to do. Yeah, I mean, and when I look at my data, that's what I was saying. A large proportion of our patients are still sitting in that like below 140/90, but in that pile of like 130s to 140s over 80s to 90s. And that's just like by convention. So I think people just have to, we are still obstetricians treating these blood pressures. So I would agree that's one of the hardest things. And this 120/80, I just changed this protocol for the RPM maybe about 2 years ago. Before that, it was like flat ACOG 140/90. And again, there's like no randomized trials whether 120/80 is better. But then, I was in this AMA meeting and a bunch of cardiologists, and everybody felt, why not? Like, why would you not control somebody's blood pressures? And my feeling is if you get to, and I have some data around this, if you get those blood pressures down to like really normal range, even if it's fine, not 120/80, even like less than 140/90 or less than 130 or close to like 130, they actually have better blood pressures at 6 months and 9 months. So I feel like if you're actually trying to control this blood pressure at least to your maximum effort in this 6-week period, you're probably gonna have some benefit long term. Obviously, nobody's done a randomized trial. I would love to do that if it gets funded, but there is some logic behind controlling blood pressures. The other thing I tell people that I have not had a single patient, and trust me, I'm pretty paranoid about this program, and if there's any kinks in the program, they come to me. I've not had a single patient who's hypotensive from any of these interventions. I'm not even kidding. Like, so it's not that people are like, having dizzy episodes because we are treating their blood pressures too aggressively. So I would highly recommend, and again, like, you have to look at your people and see how you guys are doing it, but there is no harm in treating blood pressures. That would be my plug.
Yeah, we had a pretty similar experience where we were able to get people titrate to the below 130/80, but a lot of patients were resistant with taking that much medication. And similarly, we didn't have any adverse outcomes. But thank you so much for your wonderful talk and all the innovation that you've done.
I see that Dr. Rosen has his hand up.
Thanks so much for giving the talk. I'm an MFM. I work with Dr. Rosenfeld. Hey, this is my question. If you're trying to target 120 over 80, that means a lot of your patients who are in what we call a normal blood pressure range, like, they're 130s over 85 when they deliver, like when they're pregnant, and then after they deliver, would be eligible for enrollment in your program. Like, do you actually take those patients who are not preeclamptic, who do not have a definition of pregnancy-induced hypertensive disorders of pregnancy, and enroll them to get them like lower than 130 over 80 something?
Yeah, that's such a good question. Currently I'm not. That is a good question. And I think about it too. So, these blood pressure criteria, which is like made by people, looking at, at studies, demographic, large population studies saying, okay, fine, if you're more than 140, 190, you're at high risk. So currently we're kind of sticking with like the strict ACOG definition of HDP. But if I have a chronic hypertensive who's well controlled during pregnancy, regardless of her blood pressure, she will be enrolled. So it's mostly enrollment by diagnosis and enrollment by blood pressures if you meet the diagnosis of preeclampsia, gestational hypertension. So new onset blood pressure diagnosis or an already existing diagnosis. Now this 120 over 80, I can tell you, when I look at the blood pressure, I mean, even if you look at my graphs, the proportion of patients who are less than 120 over 80 are very, very small. Majority of the patients are in that category of like less than 140 over 90, but definitely higher than 130s. Again, I think like this is something that I fancy, that everybody's blood pressure should be normal by the end of 6 weeks. I don't know if I'll ever get there, but even in my own data, 31%, for example, 46% of the people overall are sitting in this blood pressure range above 130. 14% are above 120 and only 25% are below 120. So not that I'm trying to drive everybody down, but you have a valid point. I mean, and again, you have to see, is this all needs to be treated? That's some question I get frequently. Does this all needs to be treated within that 6-week period of time? But at least with our patients, and we generated some data, about 20% of the people out of my cohort will actually go see a cardiologist or come back to see a PCP at our institution. So I think controlling blood pressure is a good opportunity within this 6-week period if you have an engaged audience.
Okay, thank you so much for that answer.
I see that Dr. Daggett has her hand up.
Hi, Dr. Rana. Thank you so much for that talk. I'm one of the maternal fetal medicine fellows here. I just had a question about, you mentioned bringing all patients in the postpartum period who needed triage for blood pressures to labor and delivery. That is also a paradigm that I feel comfortable with, but here at this institution, any patient who is in the postpartum period for pretty much any complaint goes to the ED for evaluation. I was wondering if that was a change in your institution or something that has been that way. And if it was a change, how did you get buy-in to bring all these patients who were previously going to the ED and now are coming to labor and delivery?
Yeah, such a smart question. So that's the whole to do. Took me almost a year to like get the buy-in. These buy-in word is so small, but it's like so difficult to get it. So this is what we did. We are only getting these. So first of all, the rates of readmission actually is kind of high in our institution. Is sitting at 16%. But I feel like more than 85% of my patients who come back are actually severe hypertension, and they all get treated. So it's not that they're not bogus admissions. So they are true admissions. So that's like one thing, determined that these patients needed intervention. We were not even following them. So now we follow them. So we try to bring them back. The only people who are coming back, my dear, are only patients who are in this program. All other patients are still going back for readmissions through the ED. So if you have a wound infection, if you have something else, you go back to the ED. So what we actually did was we told them, so the previous cutoff for the ED was, I think, 20 weeks. We told them we will take these patients from the ED and we will give them back. No, so it was 16 weeks. So we did an exchange. We said, we will give you back patients between 16 and 20 weeks back to the ED, but we will take these patients who are postpartum hypertension. So we kind of, because there was actually not so much resistance from ED, they didn't really care. It was resistance from my L&D triage people saying, why would we now taking more patients? So I said, fine, we will send patients down to the ED up to 20 weeks. So that will create some patients between that 16 and 20 are not going to come to you, but instead of those people, patients with hypertension will come. And then, and then everybody, the best example I can tell you for clinicians is if they have their own anecdote. So over the course of several years, everybody has an anecdote that found this patient who came to triage and was very quickly treated, and patient wrote them a nice story and said how happy she was with the program. So I think some of these you just have to like kind of give, and I'm always like telling my nurses what a great job they're doing. I give personal feedback to physicians. If their patient comes back and says the patient gives any positive feedback about the program, I quickly push it out to the team and say, you guys are doing a good job. So I think you just need to create some anecdotes. But it took me almost a whole year to convince my team here to say that these patients do not belong in ED, like lost in that, and then we have data. So the other thing you can always convince people is by data. We collected data and we showed them that average time of evaluation in the ED was like 9 hours. And we reduced it to less than 1 hour in our triage. They come in and they get treated. So one thing you can always do as a fellow and as a junior attending is to always to produce data to your words, and people listen to it, I think.
Dr. Rana,
Thank you so
thank
much.
you so much. Unfortunately, we're out of time and we're supposed to keep to a tight schedule. So
Yes.
thank you for this very invigorating talk.
Thank you. Thank you for listening, guys.
Thank you. All right. And with that, we're going to have to bring this to a close. As a reminder, the residents are taking the CREOG exam today, so the coverage is a call team. But I hope everyone has a safe and productive day. Thank you.